Hello everyone, today we'll be talking how to manage a hypoxemic patient in ICU. So you're called to evaluate a patient whose oxygen sats are at 80% and he's on a ventilator and these are his ventilator setting. Let's see how we'll approach this patient. The two step in managing this patient is step 1, finding and treating the underlying cause, and step 2, keeping the oxygen sats 90 to 92% till their underlying cause is corrected. We look at 5 physiological principles to help improve oxygenation, and these are increasing FiO2, increasing surface area, optimizing VQ match, optimizing respiratory mechanics, and decreasing work of breathing. On a ventilator, you have more access to information than a non-vented patient. Makes your making diagnosis a little bit easier. You can look at the lung mechanics and perform inspiratory and expiratory pause, and these can tell you about resistive and elastic component of the circuit and help you in diagnosis. If you have capnography, examine their waveforms. That will help you as well. The differentials are a little bit more wider than patients who are not ventilated, and there are things like tube dislodgement, tube obstruction, agitation, etc. Understand that small changes in patient underlying condition on a ventilator can result in hypoxemia since there are no reserves. First question you should ask is what are the underlying problems that can cause hypoxemia in this patient, and you're looking at two things. First thing is the chronic components like heart failure, COPD, obesity, ILD, etc. Some of these may not be relevant like neuromuscular disorder or sleep apnea as the patient is now on ventilator. Always know what was the underlying diagnosis during admission and why this patient was intubated. And make sure that you talk to the nurse who can give you a pretty good idea quickly or quickly review the chart. The second and more important question is what caused the sudden worsening of hypoxemia? And this is the acute component. Etiologies like lung collapse, flash pulmonary edema, air trapping, etc. can happen and can cause acute worsening. So before proceeding, make sure that you increase the FiO2 to 100% on the ventilator. As we discussed before, there are 3 main reasons for hypoxemia. You have neurological, pulmonary, and cardiac causes. However, while patient is on ventilator, the neurological causes are not very important cause for hypoxemia, but increased oxygen demand by increased muscular activity like agitation, vent asynchrony, fevers, etc. become more important. You can have increased resistive work of breathing as seen in airway obstruction like COPD, asthma, tube blockage, biting the tube, etc. You can have worsening elastic work of breathing, for example, developing a pneumothorax, lung collapse, worsening ARDS. You can have decreased surface area, for example, you can have mucus plugging and resultant lung collapse and atelectasis. You can have worsening pneumonia or ARDS. Fall in the LV output causes flash pulmonary edema and can worsen the hypoxemia, and it can be seen in acute coronary syndromes, arrhythmias, volume overload, etc. Decrease in the RV output can also result in hypoxemia, which is seen in acute PE, pulmonary hypertension, and any shock state. Less important cause would be acute blood loss anemia and methemoglobinemia. Before proceeding, make sure that you talk to the nurse about what's going on, and she can give you a quick summary of the things that have been going on, and you can focus on the points that would make the patient hypoxemic. For example, agitation, fevers, type of secretions, rhythm problems, blood pressure, etc. Observe the patient while you're talking to the nurse to see if he's agitated, he's biting the tube. Look at the chest wall movement and abdominal movements. Look at the secretions in the tubing and see if you hear any audible gurgling that would suggest a cuff leak. Always suction the endotracheal tube yourself and check the cuff. Make sure that you also look at the position of the endotracheal tube because ET tube dislodgements and movements are pretty common. Auscultate for wheezing, decreased breath sounds and crackles, and make sure you auscultate lung bases as well. Always palpate abdomen and check for abdominal distension. Palpate hands and legs to see if they are in warm or cold shock. Look at the ventilator waveforms while you are inspecting your patient. Look for signs of asynchrony. Perform an inspiratory and expiratory pause to look at the peak and the plateau and figure out if there is a resistive or an elastic problem. perform an expiratory pause if you believe there is an autopeep. A lot of the ventilators will also have capnogram, so make sure that you look at it. Please watch how to use peak and plateau pressures and capnogram in my previous lectures. That will help you understand this a little better. Bedside echo is a very useful technique and I would encourage you to learn it. This can help quickly differentiate some important and acute problems like pneumothorax, pulmonary edema. It can also give you a good look at the heart to see if there is a reduced LV or RV function, any acute valvular insufficiencies or tamponade. It can also give you an idea about volume status. While you are looking at the patient, make sure that you order chest x-ray early, as it can take some time for this to be available. And this should be able to help you drive some differential diagnosis like flash pulmonary edema, mucus plugging, pneumothorax, etc. EBG is not very helpful, however it can help provide information regarding pH, lactic acid and PaCO2 and hemoglobin levels, and if there are any abnormal hemoglobin level forms. EKG can help you rule out acute coronary syndrome and help you figure out what type of arrhythmias, if any, is present. In summary, know the underlying relevant comorbidities related to pulmonary and cardiac system, know the admission diagnosis, and know why the patient was intubated. Before proceeding further, make sure that the patient is on 100% FiO2. To find the cause for acute change, talk to the nurse. Make sure that you suction the endotracheal tube yourself, palpate abdomen and extremities, auscultate for wheezing, air entry and crackles. Perform a chest x-ray that will help you in your differentials. Examine the waveform on the ventilator, perform an inspiratory and expiratory pause, and look at the capnograms. Know how to use bedside ultrasound to rule out acutely decompensating diseases like pneumothorax, pulmonary edema, cardiac tamponade, etc. And order other tests as appropriate. In the next video, we'll talk about how to keep the oxygen sats 90 to 94% on the ventilator while you are trying to figure out what's going on. I think if you follow these steps, you should be able to get a fair idea about what's causing hypoxemia in your patient in a fairly short period of time. Thank you.